Firstly, hi and welcome. I'm Linda Swan. I'm the CEO of Go Gentle Australia. And welcome to all the participants. We've got people coming from across Australia to join this webinar. We had over 600 people register for the webinar, so clearly it's a very interesting and valuable topic for us to be talking about today. Before I start, I really wanted to acknowledge the traditional owners and the custodians of the lands on which we meet today. Here in Sydney, it's the Gadigal people of the Eora Nation, and it's incredibly important that we do take the time to send our respects for our people that traditional people that we acknowledge in so many sectors, but we need to do so in meetings like today as well. Go Gentle is committed to ensuring that all Australians have access to voluntary assisted dying should they choose at the end of life. And we've got a lot to do to ensure that First Nations people can have access to voluntary assisted dying. In the Northern Territory, the laws aren't even passed yet, and we know as well that there's more to be done on developing culturally sensitive and appropriate resources for First Nations people. So I would like to acknowledge on behalf of us all the fact that we are meeting on the traditional lands and pay my respects to elders past and present. I'd also like to introduce our three speakers for today. So we have three very notable figures in voluntary assisted dying. There's Professor Ben White, who has been leading research in voluntary assisted dying for over 20 years. He leads a fabulous team of researchers at QUT in Queensland who concentrate on health law and really the research about what great health law looks like, and a particular focus on assisted dying. So thank you, Ben, for joining us. We have Susan Jury, who is the Director of the Victorian Care Navigator Service. So thank you very much for joining us. Susan's an expert in voluntary assisted dying and herself leads and shares her expertise across webinars, and it's interesting to have you on a panel rather than being the chair. So welcome, Susan. And Claire Fellingham. Claire Fellingham is the clinical lead for the voluntary assisted dying service at East Metro Health in Perth. So she's joining us from the other side of the country. She's a really strong advocate for improving the health services that are associated with assisted dying and is an expert in the delivery of voluntary assisted dying care from the clinical perspective. So we have Ben here representing the research, Susan representing the care navigators, and Claire as a clinical practitioner. So a great different set of expertise. So with that, I might just jump straight into some questions. And the topic of this particular webinar is who's eligible for voluntary assisted dying. And perhaps as the expert, Ben, in the research and been in the space for so long and being involved in the development of all the laws around Australia, perhaps you could tell us a little bit of a summary and overview of who is eligible for voluntary assisted dying in Australia.
Yeah, of course, Linda, and I'd just acknowledge the Turrbal and Yagara people as the traditional owners of the land where I'm coming from today in Brisbane, Meanjin. Australia has 7 voluntary assisted dying laws, and they've all passed in a relatively short period of time. The 6 states and the ACT. The ACT law hasn't yet started. It will begin in November. Despite there being 7 different laws, there is a broad Australian model. So there's a sort of broad overview where I can speak to what the eligibility criteria are across the country. I'd probably group the eligibility criteria into 3 buckets. I'll start with the first, which is probably the most technical but can still be important, and that's about residency. So the various state and territory laws have requirements about national residency, Australian citizen or permanent resident, or some other requirement in that setting, as well as requirements to be resident in the state for 12 months prior to making a first request for voluntary assisted dying. Some states have the ability for exemptions or exceptions there, but that can be, although a technical requirement, can actually be an important one to consider. It has been a barrier for access. So that's the first one to mention. The second bucket relates to eligibility criteria about the person themselves. So the obvious one is that the person has to be an adult under all Australian laws, 18 years or over. They have to have decision-making capacity, so they're able to make their own capable, independent decisions, and they're doing so voluntarily without coercion. And I'd add that many states also require the request be enduring. So that's that second bucket relating to the person themselves. And the third is about the illness or medical condition. This is where some of the state laws can vary a little bit, but at a sort of global level, key requirements are that a person has an advanced and progressive illness and one that is going to cause their death. There's some variation in states. Some talk about incurable or irreversible as well, but advanced and progressive and going to cause death is really the key consideration across the country. When, in terms of time frame, all the states, in fact, have a requirement for a time frame. That's generally 6 months, expected to die within 6 months, or 12 months if you have a neurodegenerative condition. So a sort of a default of 6, but 12 if it's neurodegenerative. And in Queensland, there's just a blanket 12-month requirement. So all the states except Queensland, 6 or 12. Queensland is 12. The ACT, interestingly, does not have a time frame expected till death. It remains an end-of-life choice. That's still very clear from the legislation itself. The requirement is, although there's no time frame, the person must be approaching the end of their life as well. And the last little component to mention in terms of illness or medical condition is that it has to be causing suffering. That suffering can be physical or non-physical, but that's an important part of that process as well. So a fair bit of detail there, but I guess if I had to pull out the sort of the summary, the snapshot, it would be an adult making their own decisions, that they've got an advanced and progressive terminal illness that's expected to cause death within one of those timeframes or approaching end of life, and the person also has to be suffering. It is important to know, as mentioned, there's 7 different laws, so it's done on a state-by-state basis. So if you're looking for some more information about the specific eligibility criteria in your state, it's important to go to that particular detail and making sure that if you're in Victoria, for example, you're looking at a Victorian resource. The Go Gentle website has got information about the eligibility criteria in each of those states. So does the state health departments. That's got a section, a page on voluntary assisted dying. And we also have a website called End of Life Law in Australia, where you can learn some more about that as well. So that Linda, that's it in a snapshot, that broad Australian model about eligibility for voluntary assisted dying.
Yeah, that's really helpful. And we very much, when we're speaking to stakeholders, do emphasise that there is this broad Australian model, because trying to go through all the complexities of the differences between each state becomes a bit overwhelming. But I would encourage, if anybody does want to know all the details, to go to one of the resources that Ben described, or if you have a look on the chat, there is a link to our website as well where you can get some more information. But ultimately, I think one of the key messages is you don't have to hold all this information in your head. There are experts there to help support you and guide you through the process. And Susan Jury represents one of those experts. And Susan, what happens? Like, how do people even begin the process of applying for voluntary assisted dying?
Thank you, Linda. So I guess the way I see it and we see it is that there's quite a lot that can happen before actually so-called applying for VAD. And there's a lot of thinking that might go into a person thinking, am I eligible as a very first step, or is now the right time, or how do I speak to my family about this, or is it the right thing for me? And there's a whole heap of questions that can come up for people long before they actually so-called apply. But I think the first thing that's really helpful, if it's something that's on someone's radar, is if you feel comfortable speaking to your own doctor, speaking to your family doctor, your oncologist, your neurologist, whoever's your usual treating doctor, and say, this is something that I'm thinking about, and seeking their position on this. What's important to recognise, though, is that doctors' positions themselves might vary. Some doctors may not be supportive, or they may not know very much about VAD. They may think a person needs to be literally in the last few weeks of their life to access it. They might not know what the assessment process is, or sometimes they don't even know that it's a legally available law. Even in Victoria, where it's been around since 2019. So if comfortable, speaking to your usual treating doctor, but I'd also encourage people to also contact their local navigators. And in every state and territory, there is the the term might be slightly different, but there's what we call a navigator service. Go Gentle has that on their website, or if you Google, for example, voluntary assisted dying, New South Wales, or whatever state you're in, you'll find the navigator service. That's the team that I lead in Victoria, and we're a team of allied health or nurses, so nurses, social worker, psychologists, those sorts of roles. And it's our express role to help people in considering and accessing VAD. So we will help people to think about if it's the right thing for them, if they actually might be eligible, help to guide how to talk with their family or with their usual treating team. And then if they want to progress and actually apply for VAD, we will then connect them with VAD assessing doctors. And part of that is matching the right doctor to the person. So the doctor that may be willing to do home visits if that's needed, or is in the right area or the right health service, or is willing to administer the substance if that's what the person either requests or needs, depending on their illness, etc. So 2 things to do: speak to your usual treating doctor and contact your local navigator service at the same time.
Fantastic, Susan. Thank you. And having gone through the process of discussing it with your doctor, or talking to a care navigator, or talking with your family and friends, ultimately, if you choose voluntary assisted dying, the next step really is to do a formal assessment process. And Claire, I wonder if you could tell us from the doctor's perspective what that's like for people. What's it like to come and do an assessment?
Sure. Thank you very much, Linda, and hello, everybody. I would just like to pick up on what Susan just said and just reinforce the importance of actually the process of assessment really does begin with a personal self-reflection and self-assessment, and really investigating voluntary assisted dying in ways that Susan's reiterated, and then also contemplating it in ways that are relevant to you, and ideally discussing this sort of thought process with your family members and your loved ones. Because one of the things that makes the voluntary assisted dying journey a lot easier is when people have already given voluntary assisted dying quite a lot of thought, and ideally, if it's right for them, shared those thoughts and that desire to embark on that journey with their loved ones, so that when they come to meet a person such as me, a doctor who's trained in assessing and offering voluntary assisted dying where appropriate, we can have those really, really full and frank discussions that really are necessary given the magnitude of the decision that the person who's moving towards the end of their life is about to make. And just to shout out the wonderful work that the Care Navigator service do. Typically, that's how patients are put in contact with doctors who are able to offer them voluntary assisted dying. And they really are the most incredible source of support, of information, and of assistance in matching a patient seeking access to assisted dying with the right practitioner. All that being said, when I am asked as a doctor who's qualified to offer assisted dying, would you please see, Mr. Jones? What we do first of all is gather as much information as possible, so that when we arrive at the face-to-face meeting for the beginning of contemplating assessment, and in our state in Western Australia, there are a number of the points in the assessment journey that do actually have to occur face-to-face. We're allowed to use some electronic means like telehealth for some parts of the process, but the first part of the journey, given the nature of the conversations we have to have, must be face-to-face. I gather as much information as possible from the care navigators, from the sources that are available within the hospital system. I work in a public hospital, so I can draw down on clinic letters, test results, blood results, and a multitude of clinical information, including the patient's notes if they've been cared for in the hospital. And then also the patient themselves. I would make contact with the patient and say, when would be best? Let's find a convenient time. I usually allow at least 1.5, sometimes up to 2 hours for a first assessment to occur, and invite the person to have as many family members or loved ones present as they wish, as is comfortable for them during that first assessment, because really that first assessment is absolutely pivotal, first of all, in determining those all-important eligibility criteria that Ben so clearly outlined, but second of all, in establishing a relationship, a rapport with a person that, is seeking access to assisted dying who may not have met that doctor before. Typically, I haven't met many of these patients before. And so it's absolutely really important for us to have a really, really clear, protected pocket of time to explore all the eligibility criteria, but also to really just begin this all-important journey together. That first part of the assessment is the most important, because that first doctor, provided they accept that first request and they go through all of the eligibility criteria and determine that a person is eligible, they will then become that person's coordinating practitioner. And really, that is what it says on the tin. They're the doctor that actually then shepherds and guides that patient all the way through the process from the beginning to the end, if that's what they wish. And sometimes it's possible at that first assessment to tell a person that they are eligible. And sometimes I would actually need to step back and say, I'm sorry, I need to go and gather more information, maybe speak to more colleagues, more specialists. So it really is quite a unique and very, very robust assessment process. Following on from that, provided a person is found eligible, I would then refer them to a second practitioner, another independent medical practitioner who's a specialist in their field, who is asked to make a second assessment against all of the eligibility criteria. And both of those two independent doctors have to agree that a person is eligible on every single count of the eligibility criteria. There can't be any questions between the two of them. Provided that those two doctors agree, that forms really the sort of most complex and most time-consuming bulk of the assessment process. Following on from that, the person has to make a formal written request where they sign a document, certainly in Western Australia, a document that's countersigned by two witnesses to say they understand the magnitude of the decision that they're making. And then we go through a number of other steps in relation to confirming the paperwork, confirming once again with a third and final request, and then making an administration decision in relation to the way that the person would like the voluntary assisted dying medication to be delivered to them. And in the various different states and territories, that varies as to what method of administration is appropriate for a patient and what they can access. And once you've got to the end of that formal assessment process, probably the best place to leave it is exactly there, where a patient and their doctor have established this really, really dynamic and collaborative and really quite special and unique relationship between one another. And then when it's ready, when a person is ready, if they ever are ready, for some people, they will never get to the end of an assisted dying journey. And just having that knowledge that they've got the medication available to them is enough. But if and when they choose to take that next step, that's something that can evolve in the future. And that's probably a question that we can leave for another point in this webinar.
Thank you, Claire. I think the participants on the webinar will already appreciate we've got a huge amount of expertise with us today. And we did ask participants to send in questions before the webinar, and we'll get to as many of those as possible. But if you do have a question that you'd like to ask one of these experts, please pop it in the chat and we will endeavour to get through them all today. I would like to acknowledge that we have had an enormous number of questions on dementia. Whenever we hold a webinar or speak publicly about assisted dying, we do get questions about, are you eligible if you've got dementia? And so I thought maybe we'd start with that early question first. And Ben, you've been involved in many discussions about eligibility and whether dementia should be included or not. And perhaps you could explain some of the complexities about this question.
Yes, of course, Linda. And it's not a surprise to see, I guess, some of the questions about dementia that I guess have come in before this, but I can also see some in the chat and in the Q&A as well. And it's probably the issue that crops up most commonly when talking about whether the current VAD laws are fit for purpose or are the lines drawn where they should be. The Australian position, I think, is reasonably clear. It is highly unlikely that a person will be able to access voluntary assisted dying for their dementia under the Australian systems. That's super clear in New South Wales. The legislation specifically says you are not eligible on the basis of dementia. So that's excluded from the start in New South Wales. And the other jurisdictions, I mentioned before the requirement to have decision-making capacity, and also that the illness be advanced and a person's expected to die within 12 months, for example, just using the sort of the state-based approach. The likelihood of both of those conditions being met at the same time is highly unlikely, and that's the rationale for why access for dementia in Australia isn't likely to be the case. I should mention that I'm using the words for dementia quite specifically. If someone has a very early stage diagnosis of dementia, but they have terminal cancer, which would otherwise mean they could meet the criteria, they may be able to access it on the basis of their cancer or other illness. So I think that's an important distinction. It's not a blanket no, if you have dementia, then you can no longer engage with a voluntary assisted dying system. But the point is highly unlikely to be able to access it for dementia itself. There are models overseas where this is possible, but one of the things that emerges very clearly from the ethical debates, legal debates, and in fact just the practical debates is how complex they are and how challenging this issue is. One model is allowing advance requests, advance directives. A person says, when I get to a particular stage, I would like voluntary assisted dying. They lose capacity, and that is then enacted by their family. But from places like the Netherlands, although the law permits this happens very, very infrequently. It's sometimes unclear when to activate the advance directive. Will family act on it? Probably more importantly, there's a significant reticence of doctors to provide voluntary assisted dying for people who have lost capacity. They have someone in front of them who is unable to say, yes, please, doctor, this is what I want. And as a result, there are very, very few cases in the Netherlands. And the other issue that's sometimes raised, which adds to the complexity, someone might be intent on receiving voluntary assisted dying, but partway through their trajectory of their illness, they may change their view. And if you ask them, do you want voluntary assisted dying, they may say no. So a great deal of complexity for the advanced directive model. And where it's legal, it's not used a great deal. The other approach is to allow access while a person still has decision-making capacity. And again, legal in some jurisdictions overseas. This often involves assessing a person who's in the early stages of dementia to make sure they retain decision-making capacity and keep assessing until that point where there's concerns they may lose capacity. It's called the 10 minutes to midnight approach. And at that stage, the person could have access to voluntary assisted dying. Not possible in Australia because they wouldn't be expected to die within 12 months at that point, for example. And some of the challenges that arise with that is those capacity assessments can be very, very difficult. And it also requires a person to say, I would like to have access to voluntary assisted dying, despite I may have many years of unknown quality of life left. So very, very difficult issues. Ones that will continue to come up. The international models provide some thought for how it could be considered for here in Australia, but the evidence to date has shown that they have been challenging as well. I think what we need in Australia is evidence-based thinking on this. We are doing a research project trying to understand better how these international models work, things like feasibility and acceptability of that in Australian conditions, what health practitioners think, what people with dementia think and their caregivers and the community thinks. So there is work happening on that. But I think one of the very clear things that I would say on that is how complex it is from a legal, ethical and practical perspective.
Thank you, Ben. For anybody that is interested in understanding more some of the complexities around access to dementia for people, I would like to encourage you to have a look on the Go Gentle website. We've actually done a bit of a paper that does describe some of the complexities around voluntary assisted dying and dementia. Many of the topics that Ben already went through are there in a bit more detail. So it's just a resource for you to have a look at if you want to understand in greater detail why there's not a simple answer to the question about can we have voluntary assisted dying for patients with dementia. But thank you, Ben, for that explanation. It's not straightforward. The other tricky element we sometimes get, and Claire, this is a question for you, is sometimes people go all the way through the process and they're approved for voluntary assisted dying, and then they lose capacity, then their dementia progresses or their neurodegenerative disease worsens, and they can no longer voice their wishes. How do you deal with that situation?
Thank you, Linda. Yeah, I'll say from the very start, it's a very, very challenging condition. Very challenging thing to arise in a patient's voluntary assisted dying journey. And I myself encountered this, at the very beginning when our law was enacted in July 2021. Not long after that, I ran into this in real life. And it was very, very distressing because we hadn't adequately projected forward into the future to anticipate that this might happen in this particular patient's journey. And so we hadn't been able to set those expectations that hinge on that absolutely fundamental part of the voluntary assisted dying law, the V part really of the voluntary assisted dying law, which is that a person themselves, right up to and including the moment immediately prior to substance administration, must be able to tell their doctor, the voluntary assisted dying practitioner, that yes, I understand the implications of this, and yes, I want to go ahead. And very sadly, even if a person has gone all the way through that journey and been found eligible and then loses capacity, they do unfortunately lose access to voluntary assisted dying. What I do now in my personal practice, having had significant lived experience of this, once and once only, is I begin the conversation about how important capacity is from the very first time I meet that patient. I talk through all the eligibility criteria, and I really, really reiterate that a person must retain capacity throughout the journey, and if they lose it, they will lose access to assisted dying. For some people with some conditions, that's really challenging because there is that possibility, like quite a real possibility, that they will lose capacity. And it becomes a really difficult journey for them. Like, when is the right time? When will be the right time? I really don't want to be robbed of this opportunity to use assisted dying. And all we can do is really help the individuals that we're caring for to try and make the right decision that's right for them, but in the knowledge that we can never, ever flout or break that really fundamental part of the law and just go ahead and administer the substance. I think the other thing that's really important to remember, though, is that if a person does lose capacity, typically that occurs very close to the end of their life. And what still exists in that space is all of the wonderful, wonderful care and support that can be offered in a palliative care spectrum. We have incredible doctors and nurses who work both within the community or within hospitals and hospices. And we have a range of medications that are available to help support the sometimes distressing symptoms that patients can have right at the end of their life. So I think it's important to remember that even if a person isn't able to complete a voluntary assisted dying journey because they lose capacity, we still do have many, many different ways to mitigate suffering, ways that exist, in the Northern Territory that doesn't have a law yet, and in other places around the world that don't have assisted dying laws. So we don't abandon people, and people won't be left to suffer.
Incredible answer. Thank you. And while I've got you in the hot seat, I'm going to give you another tricky one. So another question that we get is for people that have chronic suffering, but perhaps not a terminal illness. So perhaps they've had a terrible arthritis that they're crippled from and they're struggling with daily activities and in constant pain. Do you get people like that asking for voluntary assisted dying, and are they eligible?
Yeah, again, another very tricky question. Thank you. Oh gosh, yeah, the answer to this is quite multifactorial. I mean, ultimately, the answer is that we are bound by the laws that exist in the states and territories in which we practice to only offer voluntary assisted dying within the framework of that law. And there isn't a doctor in this country, or presumably in the world, who would choose to deliberately break that law, irrespective of how much they identify with a person suffering, because to do so would it's a criminal act, and it would ultimately, if proven in a court of law, result in that doctor not being able to practice medicine anymore. But that being said, sitting with another person suffering is a deeply challenging thing to do. And it's one of the things that we do in the voluntary assisted dying space all the time. We deliberately act to tease out a person's suffering and sit with it and explore it and really, really listen to people, often in a way that they perhaps haven't even been listened to before. So whilst a person with a non-terminal but significant condition causing suffering won't be eligible for assisted dying, it doesn't necessarily mean that they can't have a voluntary assisted dying assessment. And that assessment itself can be quite cathartic and can be quite palliative, partly because we can explore whether or not there are other options available to the person, other physical or psychological or specialist interventions that we could offer a person. And sometimes just being able to sort of get in amongst a person's suffering and hear them and offer them other avenues is helpful. And it's important to remember that suffering, it's subjective and it's context dependent, and what counts as suffering to me might be an experience that is completely different to somebody else, even if the circumstances of that suffering are the same. So it's not something that we externally judge. It's something that we do explore and really will try and work with people to help to try and alleviate to the best of our abilities. But ultimately, no, unfortunately, suffering in the context of a non-terminal illness is not eligible for access to voluntary assisted dying as it stands.
Thanks, Claire, and I promise I'll try for an easier question next time. We've had a broad range of questions that have come in, and I think it might be timely to address some of the questions that have come in before the webinar, but also on the chat throughout the conversation. But I thought an interesting one to start off with was a question about the cost. We had a question from a participant to say they have cancer, they are unable to travel, and they're really curious about how is the cost of voluntary assisted dying covered, and what costs might they incur. And perhaps, Susan, you might have the broadest experience in answering that question.
Yeah, sure. So voluntary assisted dying is a public service, but within that is, so for example, from the Victorian perspective, is that if you're seeking assessment for VAD and you're in a public hospital or in either as an outpatient or inpatient, there won't be a cost to you because that's within your cost of your public health care. There's no cost to the substance that's provided as part of the service. Sometimes there is a cost associated with seeing doctors privately in Victoria. Some doctors will see that they may charge they may charge Medicare for a complex assessment, but there may be an out-of-pocket cost on top of that, or they may charge the full fee. So that is something to ask your navigators what the cost might be to you, because that's very, very dependent on which doctors you're connected with, whether you're in a hospital or not, and also which state you're in. Now, most if not all of the states and territories also have some funding by the government.
Staff respond code
Sorry.
blue, 5C CT imaging. Attention staff
Sorry.
respond blue, 5C CT.
Okay, thank you. So that's I'm in the hospital. So yeah, ask your navigators about the cost, and as I say, there are funds available to cover the costs if finances are a barrier to you or an issue for you. So always ask your navigators, because no parts of Australia want finances to get in the way of accessing VAD. Hope that answers that.
Yeah, absolutely. Claire, we had a question about counselling and how not only does the person going through voluntary assisted dying, but their family gets support, because some family members don't necessarily understand or agree with a person's choice to access voluntary assisted dying. And then we also hear that the death or supporting someone through a death in voluntary assisted dying is different from a normal death. So there's sometimes different type of grief. And we're wondering, is there some counselling services available for participants and families?
Thank you, Linda. I think I can probably only answer that from the Western Australian perspective. I'm not 100% sure exactly what happens in other states. And I will say off the bat that Western Australia was the second state to legalise assisted dying after Victoria. Thank goodness they went first. And it just wasn't something, the unique nature of the bereavement support, both the anticipatory grief part and the aftermath of assisted dying, it just wasn't something that was on our radar because we had no lived experience of offering this care. And so what has happened is that services have sort of had to catch up because there wasn't anything in place initially in relation to this quite unique and complex grief. What we have found, though, is that over time, with the sort of growth in public knowledge of voluntary assisted dying, we have both professional networks. So, and again, picking up on one of Susan's comments before, speaking to your own doctor, your own general practitioner, a doctor that you already feel comfortable with, or a nurse or anyone else in the healthcare journey is often a really great source of support. There are professional services. So over here in Western Australia, Griefline and Beyond Blue and some of the sort of bigger publicly available grief services are actually now acknowledge that voluntary assisted dying is a particular form of grief, and they have specific grief counsellors who are able to offer specific grief-related care. But I think one of the best things that's emerged from this really just a bit of a void in what's there is that we now have an incredibly supportive peer group situation. We actually have in Western Australia a group who've established themselves of people with lived experience of caring for people accessing voluntary assisted dying, who are able to offer a safe place either through online and social media mediums or through quite regular meetings within the city of Perth, typically, for people to be able to actually go and share their experiences with people who really understand and get where they're coming from. And in my experience, not just in assisted dying, but in most realms, that kind of peer support, that lived experience, that word of mouth and that real just kind of core insider knowledge doesn't really have a substitute out there in the kind of professional realm. And I would strongly encourage you, anyone who is, feeling that they want to speak to someone because they're really kind of challenged and dealing with these complex feelings that come from an assisted dying journey, to reach out either through those networks if you can find them, or through your local care navigator service in the state in which you're in, who also, to be honest, in Western Australia offer patients an incredible amount of really, really deeply qualified support, and also their families as well, and work very hard with patients and their families, particularly if there is that sort of disparity in belief about whether or not this is the right thing for a person. And really the combination of what's out there from the care navigators in a professional spectrum and then in that lived experience space is really fundamental to helping with that grief process.
Thanks, Claire. And Susan, did you want to add anything to that? Different state, different approach?
No, I think it's the same across Australia. It's evolving speak to navigators. And I think that, I guess the other thing is what we are learning is that there is uniqueness to the VAD experience, and definitely, and grief counsellors are becoming much more familiar with this now over time. Yeah.
Ben, I've got an interesting question for you from the chat, and it's on a related topic. If a family member strongly disagrees with a person's choice of voluntary assisted dying, can they pursue legal action to stop that person from going ahead?
We haven't seen this unfold in terms of a sort of public legal litigation in Australia. There has been some of this happening occasionally, very, very rarely in other countries. In Canada, it happened once, and the court, its view was this is a clinical assessment. There's a careful process set up and there's a legal process established for that. So in that instance, the court there said they weren't going to intervene. It is possible in Australia. There's some eligibility criteria like capacity, for example, which can be tested or assessed by civil and administrative tribunals, or in New South Wales, it's the Supreme Court. So that is one possible realm for that. But I think in instances where a person clearly has decision-making capacity, and if this is based on or grounded on different ideological views, I think it would be a pretty direct reception from a court or tribunal who, if there's a family member saying, I don't agree with this decision and I don't want them to go down that path, I think they'd be very, very clear in saying that's not an appropriate use of legal machinery of the courts or the tribunals. That's not to say there wouldn't be discussions, and Susan, for example, I suspect dealing with the full breadth of family reactions and experiences. So that would be my response from the sort of the formal legal response, but I don't want to put Susan on the spot, but I also know you have lots of experiences with those families.
Thank you, Ben. And you're absolutely right. It depends on, I guess the question is whether people are objecting from a personal ethos or from a worry about the person's capacity or eligibility, etc., which, Ben, you answered beautifully. From that personal ethos point of view, we absolutely do have families on occasion that don't support the person accessing VAD. What I've observed is that sometimes when the person is earlier on in their illness, it can be very hard for the family to grapple with it. And sometimes the family is a little bit behind in catching up with the person themselves, thinking about their terminal illness and what end of life looks like for them. And sometimes it just takes that time for the family to catch up. Sometimes we encourage, like Claire said before, for family to come to the assessments, to actually be part of the assessment process, to meet with a navigator so they can have that chance to explore what the suffering and what VAD really means to the person accessing VAD. Ultimately, the person themselves, it is for them. And we have had people on occasion who have chosen to not tell their family that they're accessing VAD, or to not tell them until the very last minute. And we have to act on behalf of the person themselves. It's their right to access it. But very much ourselves and the assessing doctors will be very much working with how to bring your family along for the ride. And sometimes we find that the families say, I don't support VAD, but I respect you and I respect your wishes. I won't be there on the day. And individual approaches are found to kind of, I guess, to meet the needs and respect everybody involved.
Thanks, Susan. Ben, another interesting question for you, and it really links back to some research I mentioned earlier that you've completed on the awareness of voluntary assisted dying in Queensland. Ben's research comprehensively showed that there was a low level of awareness in Queensland, and it's probably true in the rest of the country, about 20% awareness. It's pretty terrible, really. And the question has come, so what role does the government have in raising awareness about voluntary assisted dying? How can we encourage governments to do more? So I wondered if you had any thoughts about what we can do to raise awareness.
Yeah, absolutely, Linda. And you're right, that research did show. So Queensland passed its laws later than, for example, Victoria and Western Australia. We have on the webinar here. But the law had been enforced for about 17 months and it had passed sort of 15 months before that. So there was a fair chunk of time for the community to become aware of it and know. And it was only 1/3 of, once we surveyed 1,000 adults in the community, and only 1/3 of folks who responded to the survey knew that VAD was legal. Susan mentioned before actually that some health practitioners don't know as well, and this is, I think, an important point to pick up on too, because we had some health practitioners in our survey, and that figure got up to 62%. So still a significant, almost 40% of health practitioners didn't know VAD was legal in Queensland. In terms of responsibility for, I guess, supporting that community awareness, I guess I'd applaud Go Gentle for its work more generally in terms of making sure this is an accessible option for people to be aware of. This webinar is a great initiative, I guess, as part of that. Now, I guess we're in Advanced Care Planning Week as well, so important to acknowledge that as part of those wider conversations of end of life, it would be nice to think that discussions about voluntary assisted dying could also be included in some of those conversations too. In terms of responsibility for it, I approach this issue as a health literacy one. When we think about other health services, how do we make sure that people who might be eligible for screening for disease XYZ are aware of that and know they can access that? I think that's a shared responsibility. I think there is some responsibility for governments now that voluntary assisted dying is a legal health service to take steps to make sure that people can be aware of that. Some stigma still remains. For some, it's a controversial healthcare choice. And so that can be difficult politically for governments, but I think there's a place for reliable, accurate, balanced information that just lets people know that this is available. But I do think it's a shared responsibility. I think health services, I think aged care facilities, I would add that to seniors groups, groups which support particular illnesses. I think we all have a responsibility to think about the people who we are interested in caring for and supporting, and think about what their needs might be. And if that means where the law permits, there's some challenges in Victoria and South Australia in raising voluntary assisted dying. Where the law permits, I think there's a shared responsibility across multiple actors to make sure people for whom voluntary assisted dying might be a choice they want, that information is provided to them and they're aware that that is a choice they may make.
Yeah, I love the idea of it being really an effort across all the spectrum of our society, from families chatting to each other and friends talking to each other and community groups to hospitals and government and advocacy groups. And there's obviously a lot more that we have to do. I wanted to also, a trickier question, Ben, that came in, voluntary assisted dying, because it's wrapped in a law and there was so much concern about ensuring that it was implemented safely, does have a pretty clear and quite unique governance process with the boards that are put in place in every state. We've had a question about those boards and what are their role in the decision-making process. Are you able to speak to that?
Yeah, of course. And I think it's fair to say the point you made about voluntary assisted dying and its unique governance, I don't think there's or certainly not an end-of-life decision. There's very few decisions in healthcare generally which are as closely scrutinised as voluntary assisted dying. When we think about the other ways in which people might make decisions, for example, that might lead to their death, withholding, withdrawing life-sustaining treatment, relying on an advance directive, the scrutiny that we see in voluntary assisted dying, it really is, I guess, that next level. And a key part of that is the oversight boards. There is some variation across the country, and some of them have specific roles in terms of making sort of final approvals, so final consent to go ahead with voluntary assisted dying. So that does vary state by state. So I'll focus on, I guess, the overall oversight and monitoring. So those roles are really, really significant. The oversight one involves checking cases of voluntary assisted dying. Practitioners are required to complete a range of forms and information, and those are scrutinised by the boards to investigate compliance. And was this done according to the very strict legal process set out? So that's the oversight component. And there's also a monitoring component, which is not so much about individual cases, but looking at all of the data across the state and how voluntary assisted dying is working. If we think about, again, I'd use the health analogy. I spoke about health literacy before. If we think about voluntary assisted dying as a healthcare choice, the same things that we want for other healthcare, like having enough data to make decisions about how the system's going, a quality improvement focus, that monitoring role enables the gathering of who's accessing voluntary assisted dying, for which illnesses, how long it takes, and that sort of data. And that data is publicly available. And so that allows further scrutiny both by Parliament. Those reports are tabled in Parliament and carefully scrutinised there, but also open to the wider community to see how voluntary assisted dying is working in practice in their state.
Yeah, so it's incredibly heavily governed, and, in many respects, we'd love all health services to have this level of governance. The positive thing about this level of governance is the transparency and the ability to show very clearly that the voluntary assisted dying services across Australia are working well and as intended and delivering safe, compassionate voluntary assisted dying care. So it's very reassuring to see that public data on the performance of the VAD services around Australia. If anybody does want to understand it in a bit more detail, we do have a report, again, on the GoGender website. That's the State of VAD report that really summarises the reporting of the voluntary assisted dying services around Australia. It's a great read, but you'll need a big cup of coffee to get through it. I have another question that's come up a couple of times, and I think this one's for you, Claire. And it's about people that have neurodegenerative disease or for some reason lose the capacity to articulate their desires and their choice towards the end of life. Have you dealt with patients like that, or how do you deal with patients like that?
Thanks, Linda. Absolutely. So I would estimate that in Western Australia, and I think it's broadly similar in other jurisdictions of Australia and around the world, that somewhere between 10 and 15% of patients seeking access to assisted dying would be doing so on the basis of a neurodegenerative condition. And in Western Australia, as I believe it is in most other places, that would mean that a person would need to be, on the balance of probabilities, approximately 12 months away from the end of their life. Now, by far and away, the most common condition would be motor neuron disease. And very sadly, for people diagnosed with motor neuron disease, it is still completely incurable, ultimately fatal, and typically people will die within 2 to 5 years from presentation. And there are various different variants of motor neuron disease which have a reasonably predictable timeframe towards death. In Western Australia, we have established a very good working relationship with some of our neurology specialists who are often willing to prognosticate for their patients and actually will assist patients by giving us the sort of, that prognostic window that, yes, I believe that my patient is within the last 12 months of their life. And that's obviously very reassuring to us as people who offer assisted dying. And then that's a very important part of the puzzle for the voluntary assisted dying journey for that patient, because it then gives them that knowledge and the scope to make the decisions that are right for them. What's really important about neurodegenerative diseases is, number one, that they obviously have to fall within that prognostic window, but there's the two differences between conditions that cause a loss of capacity, like an actual loss of decision-making capacity, and conditions that render a person unable to communicate using speech. And I really want to reiterate and reassure people that, as we've touched on before, if you have a neurodegenerative condition which will cause you to lose capacity, you do have difficult decisions to make in terms of timeframes of accessing assisted dying before you lose capacity, because there is no sort of fudging that one. You cannot get around the point at which capacity is lost. But if, for instance, you have a form of motor neuron disease like that causes a bulbar dysfunction and inability to speak, but you still are able to communicate by other means, by means of typing, by means of verbal gestures, by means of even eye gaze, to be honest, and you retain the capacity to be able to communicate with the people involved in your care, then you can still access assisted dying. And that's really important, because we don't want to prohibit people with a physical disability as part of their disease process from being able to access assisted dying. And that applies to conditions outside of the neurodegenerative spectrum. For instance, big head and neck cancers or other conditions where people may lose the ability to verbalize but are still able to communicate by another means.
Fantastic, Claire. And before you turn your mic off, one more question. We had a question about the training. How do you go about becoming a voluntary assisted dying trained practitioner? What's involved? Can you give a bit of a snapshot about what the training's like?
Sure. So again, slightly different in different states and territories, but from the Western Australian perspective, a doctor who wishes to offer voluntary assisted dying, and as it stands, everywhere apart from the ACT will require a doctor to be the main, or two doctors to be the main people involved in your care, as opposed to any other health professional. You have to be a doctor of significant standing in your own right. So you have to be a specialist, a qualified specialist with at least 1 year of full-time equivalent practice under your belt, or a general practitioner with at least 10 years of experience under your belt before you're able to embark on the training for voluntary assisted dying. If you fulfill that circumstance and you wish to undertake the training, then you flag that with the Department of Health, and they will go through an assessment and an eligibility criteria to make sure that you are really who you say you are, and that you're the right kind of person to offer this care. Provided that you fulfill all of that, and it sounds like a lot, it's not a lot. We want to very strongly encourage doctors who wish to enter into this space to be able to access it, but obviously we have to safeguard patients from just anyone being able to offer this care. Once you have sort of fulfilled those criteria, you do a special training module that was actually developed by the Queensland University of Technology. Really, really, really comprehensive, descriptive and robust online training package, which is a number of different modules, I think 9 from memory, which takes a good solid chunk of time to do, at least probably a day of sitting down in front of a computer. And then there's an open book exam at the end. So it is an exam with a high pass rate, but you're not expected to remember every single thing about voluntary assisted dying. You are allowed to refer to the texts, which are important for us to be able to draw down upon and pass that exam at the end. Provided you meet all of those criteria, you are then given a statement of completion and a sort of certificate of currency of your ability to offer voluntary assisted dying training. And in Western Australia, that's valid for 3 years. And at the end of 3 years, if you wish to continue voluntary assisted dying and you have offered this care, so you have actually cared for patients within the year prior to your training running out, you do a refresher, which is a shorter module. But if you haven't cared for patients or you've forgotten everything or you choose to do it again, you can do the whole training all over again. So, I think it's important. It's not onerous. It's not too onerous to do, but it does require a lot of involvement because the gravity of the decisions that you're helping patients to make ultimately are very significant. But it's a very, very well curated and well developed training program that ensures that people get the care that they need.
Thank you, Claire, and thank you for the work that you do in this space. It's incredibly important. We're coming towards the end of the webinar, and I thought it might be useful to just wrap up a few of the key messages that we heard. Really, this was about helping people understand, are they eligible for voluntary assisted dying, and how do you go about finding out more about eligibility? We've heard a lot of information here, and this webinar will be made available on our website so people can watch it again if they'd like to, or share it with their friends. We've also talked about a few resources that you could go to. Your state health departments will have information on voluntary assisted dying and the assessment process. Go Gentle Australia's got a lot of information on our website. But Susan said to you, of course, talk to your usual doctor about your thoughts and your wishes in this space. Talk to your family and friends. Not all healthcare practitioners will have completed the training that Claire just described, but they should be able to give you enough information to help you do things like access a care navigator service such as Susan's service, or steer you towards one of the other sources of information that we've talked about. And then if you do have the good fortune to fall into Susan's hands or someone like Susan, you'll find they're incredibly supportive, well-trained people who really understand the process and the complexities of the process. And Susan and her team not only support participants' families, but they also support health practitioners who also need sometimes to call and phone a friend and ask for some advice. So Susan, given that we consistently hear that you're the heart of the voluntary assisted dying service, did you have any final words or final advice for people if they are considering voluntary assisted dying? Any steps where to do or what not to forget?
Sure, a 30-second wrap. Just to note, I'm not the heart of VAD. I mean, we've got services all around Australia, and I know that Claire, you work with an amazing team in WA as well. So, but thank you. My kind of, I guess, my final pieces of advice is, first of all, as you said, Linda, speak to your usual treating team, or Claire said your doctor, whether it's a nurse or doctor, whoever it is, speak to someone, but also call the navigators, even if you've only just been diagnosed and you're definitely not eligible, but you're exploring it, to think about it. We as a national service take calls from family and friends. We take calls from anybody, so it doesn't have to be the person themselves that calls us. And encourage your doctor to call us. If your doctor's wanting to know about the training or is not quite clear in it or is a bit confused, say to them, call the navigators. And I guess the last point is that like Claire also said, a number of people in Victoria, about 30% of people, they go through the assessment process, but they don't actually use it, but they get this enormous comfort in just knowing that they've got the option. So don't even begin to think that because you call us or because you go and see Claire for an assessment or you have all your assessments that then you are under any obligation to use it, because you'll hear time and time again that you're not obligated to ever use it. Just the comfort of knowing that it's available if you need it is enough for many people.
So time to draw it to a close. There's unfortunately many questions we didn't get to. My team here at Go Gentle will endeavour to answer as many as we can after the event. But thank you to Ben, to Susan and Claire. I'd like to do a quick call out to say Go Gentle Australia is a charity. We do rely on the support of people like yourselves to keep us going. So if any of you could support our work and go onto our website, we'd be very gracious for any donations or support. Thank you, Ben. Thank you, Susan. Thank you, Claire. Have a great day.
Thanks, Linda.